peek behind the curtain of the Softly Training Lab with the Softly Performance Podcast. The pinnacle of human performance is out there, and we intend to find it.
Got it. You're live.
Welcome to the next episode of the Softly Performance Podcast. I'm your host, Coach G, and with me I've got Coach Matt. Today, we're talking about a couple things. Obviously, if you're listening to this, you are more than aware. There's been some changes on the DOW side as far as, let's say, the norms. So, for example, waist to hip ratio, which we're not going to be talking about today. I don't know enough about it other than that no matter what doctrinal change you pass down, you're going to piss somebody off. And also what I really wanted to talk about today was just our thoughts on testosterone screening. If you've been listening to this, you will remember, particularly if you haven't, I would suggest go listening to Dr. Nick Behringer's podcast episode with us, where towards the end, he starts talking about the value of blood testing specific to military first responder communities and how it would be nice to have some kind of baseline. You can imagine people are coming out of the woodwork, and I don't know, criticizing it on the surface, because I understand why. And Matt, I'm sure is in the same frame of mind in that on the surface, it doesn't sound like a great idea, but we need to start somewhere. And I do think we should be measuring something. I'm more interested in the longitudinal data that we'll potentially see over time. We don't have that right now. I mean, it's all downstream. But if you have a baseline...
sorry to cut you off, mate.
No,
just for people who aren't plugged into like DoD stuff, can you explain what the policy changes?
Yes. Okay. Now
are looking like.
Now, true to the theme, I think, of the direction of the podcast, we want to take this in. It's not like I'm not going to sit here and read the Marine Corps Order Papa 1020 Golf. I can't believe I still fucking remember that. I'm not going to hear and read exactly verbatim what the doctrine says. I'm just going to paraphrase what the current Secretary of War, Hesketh, is saying. Essentially, we want to start screening people for testosterone and low testosterone levels. That's the idea. So hypothetically speaking, you're in this high threshold, high stress, high cortisol demand environment for extended amount of time. Theoretically, your testosterone production should be lower. And the question is, should we be, the idea or aim is we will now start testosterone replacement therapy for you if you qualify and you're marked as low. So all that being said, Matt, I feel like if I just talk, you're probably going to have the same ideas that I do. So what are your thoughts when I say, hey, we're going to start screening people for testosterone, low testosterone in a Department of War or Defense?
Yeah. So I think like you, I think it's potentially a really positive step in a really positive direction. I think it's like a lot of integration of new tech and new ideas and things like that, like with the machine learning and the AI models and things like that. I think that we have to start moving in the right direction and be prepared to kind of stumble, like be prepared for it not to be perfect out the gate. Now, I think the kind of the big caveat to all that is that this isn't machine learning. This isn't tech as such. This is medicine. And anytime you start doing stuff like that, again, like, let me finish my point first. Anytime you start doing stuff like that, a bit like with scanning and things like that, it's all fantastic to have the access and the ability to do that. You do run the risk of over-medicalizing people. I think I have to be a bit careful talking about this stuff because culturally, you guys are in the States, you are very different to us in the UK with how you sort of view the medical system and your kind of...
You can just say it, man. You don't have to pay for healthcare in the UK.
So we don't have to pay for healthcare in the UK. In the military, it's kind of a very similar setup. It's to you guys in that it's private. I have noticed in just kind of broader society since living in the States that you guys are kind of way more focused on like medical intervention early on as opposed to kind of lifestyle stuff. And that's not always a bad thing. Like some of the research and stuff that's getting done and some of the protocols that you guys have available are like light years ahead of what we have on the NHS, which is the socialized medicine system in the UK. Just for clarity, if you serve in the UK, you're under effectively private medical, so that stuff doesn't apply. But so I think that's not always a detriment, but I think that is something that we have to be aware of, where you're potentially risking, like, I'll see in the trees from the wood, like you're potentially risking creating a problem that isn't there because you're like overly testing and overly medicalizing things. And we know that stuff like testosterone is an incredibly valuable and useful insight, but we don't want to become overly reductionist and like make it binary. Either you're good or you're bad in terms of testosterone levels, because it's so multifactorial.
Well, yeah, when you say multifactorial, that's exactly where my head goes. I mean, the immediate response, the practitioner in me is like, okay, that's fine. What's your sleep look like? What's your alcohol intake? Those common sense things that we've been beating like the war drum forever. Because you could, like, that's who I'm thinking of, the shitbag who I served with, who does not take care of themselves, borderline light duty in the med bay all the time because he's so busted. Well, he's doing all these things wrong. Of course, he's going to have low test. So yeah, sure, you give him more tests. Here's the other thing that people don't consider. That can be potentially, it's a non-zero chance, a lifelong thing that you have to do.
Yeah.
Right? So once you open that door, you're replacing hormones. You have to do that for the rest of your life, potentially.
And that's true on both. So we should stress that neither G or I are kind of qualified in medical practitioners. So we're talking about this from the perspective of a strength and conditioning coach. But that's both true on like a physiological, but also like a psychological aspect. Physiology is like you said, we know with often with hormone replacements, like your own production is going to start to ramp down, and we don't always see that come back up when you wean off it, for want of a better term. But that's equally true psychologically. If you know that you've got like a get out of jail free card, if you get used to, it's okay, I can keep running 3 hours of sleep, I can keep snorting pre-workout. When you then have that taken away from you, and there's very real side effects associated with TRT, so it might get taken away from you at some point. Yeah, that can kind of lead people to crash and burn, I think.
Shit, man, you like lead to getting taken away. I can't even consider like the level of chaos that's currently involved with the veteran healthcare system. When I say veteran, I don't mean active duty. It's very whiplashy. Right? And it's very much under attack. So I can only imagine if I'm active duty, I get screened and they're telling me that I need testosterone replacement therapy and it's approved right now. We don't know what it will be in 8 to 10 years.
Yeah. That's a great point. I was sort of more going down the line of if God forbid you kind of discovered that you started having like a tumor or a growth or something like that, or other health complications. TRT might be a contraindication. It might be a substance that negatively impacts whatever those complications are further. So you might be forced to come off it. That's what I was going. But yeah, you're bang on as well from a kind of an economic perspective, I guess.
Well, and then it reminds me of, I'm going to get a little metal here. My wife and I's, her pregnancy and her birth. We went very, let's say, lo-fi. And she did not require the use of an epidural. We did a lot of, just like I would do with this field, I did a lot of reading, not at the level of a doctor, but very much at the level of a, let's say, more clinical approach. If you guys are wanting to know what I read, there's an amazing book that doulas use. I can't recall. You know what? I'm just going to look it up, dude. Because that book was fucking awesome. And people deserve to know about it. Because it was written, one of my frustrations with what I was finding, a lot of it was very surface level, written from the perspective of someone who didn't give a shit. Like the dad smoking in the other room kind of thing. You know what I mean?
Yeah.
So, and it was irritating because it wasn't giving me anything I didn't already know. Like one of the books I couldn't stand. One of the few books I've returned. Like it pissed me off. Like that, I took it to Amazon. It's like, this book sucks. Was talking about, oh, now your life is going to be different. You can't go hanging out with your buddies and going to the club. Yeah, no shit, dude. Like the book was not for me.
Hold my beer.
The Birth Partner. You know, it's funny. Memory's funny. I just remembered. I think it's called The Birth Partner. Yep. Birth Partner. Okay. So I read this book called The Birth Partner, the 5th edition, which is a book meant for doulas. So doula is someone who will assist you through your pregnancy. They are an agent for you versus the doctor, who at the end of the day serves a hospital. For the doctor, the medical doctor, it's fucking Tuesday for them. And I'm not discounting the amount of the work that they do. We used a medical doctor for our pregnancy as kind of a backup because we actually had a miscarriage prior to that. So I'm not saying that, they're too clinical, whatever. No, we respect the medicine in the field in that domain, but we needed somebody who had our own best interests in mind. And that's why we hired a doula. But anyway, this is the same book or manual that they would read. And one thing I learned and took away from that book, outside of all the technicals that we're not talking about birthing today, was the notion of medical intervention or clinical intervention. When you open that door, the solution, so meaning if I have an epidural, if I'm a woman and I'm going to have, and I'm birthing and I ask for epidural, the next stage, if something goes wrong, has to be clinical. You can't go backwards. You can't be like, I changed my mind. Let's go back to doing, I think I can handle no. Like if something goes, they have to. So what ends up happening, and they call it a cascade, it keeps going and more clinical and more clinical and more clinical. And I'm not, every birth story is different, but we also went to classes to get ready for. And afterwards, we all get reconnected and everybody talks about their birth story. And there were some really, really, really rough ones. And it's because they kind of opened that clinical door. And when they're talking about their stories, like, and then the doctor had to do this, and then the doctor had to do that. So I say all that because this is kind of the same, this raises the same question. If you start addressing things hormonally through I shouldn't say supplementation, but you're injecting testosterone, not unrelated to what you were talking about, maybe the inverse, Matt, where you have to come off of it. Well, now you're not operating normally as against a normative population. You are now different. So therefore the solution for whatever ails you may have to be different. And that's, you don't have as much control there.
Yeah.
Whereas if I told you, hey, you need to get more sleep, you have more control. Well,
that's kind of what I was gonna get at next. I guess in an attempt to sort of turn the tide on being super negative about like opening about this. I think modern Western healthcare is phenomenal. I think it's some of the procedures and some of the tech and some of the things that are accessible and available now are absolutely incredible. But I think where the strengths really are is like acute traumatic care, like getting shot, getting stabbed, getting hit by a car. The life-saving stuff that medicine can offer now, Western medicine can offer nowadays, is insanely cool. Where I think we are perhaps less effective is like the kind of the chronic care.
Yeah, I agree.
Yeah. And so I think that actually is where policy changes like this, assuming that it's not abused or misinterpreted, I think that's where this kind of stuff could be really useful because it's potentially
what's more
like giving warning flags earlier in that pathway so it doesn't become acute. It doesn't become like this person has to get to hospital right now. It becomes like a course correct, like you were saying, where you can start talking about lifestyle factors and things like that. Because some people, TRT is probably the most appropriate course of action, but you have to make sure that all those kind of lifestyle factors are in check first of all, I think. And again, that's where there's real potential in this.
Well, you mentioned the dean of school of medicine at Stanford says that the U.S. has the best sick care system in the world. It doesn't have the best, I'm paraphrasing what he's saying. It doesn't have the best healthcare system. So you're right. This is a step towards healthcare, not sick care. And I'm for this in that what military and first responders have to do to their bodies is not normal. You're not supposed to, physiologically speaking, keep yourself up for more than 24 hours. You're not supposed to, you can go without food for 72 hours. You know what I mean? So like, I think these are, So I say that because, well, now you get this baseline assessment before you're theoretically fucked up. Now you at least have an idea of where you should be when you're 40, 50, 60. So yeah. And I think, Matt, people, listeners, hopefully understand we're not saying, oh, testosterone replacement is waste of time. No, we're just saying, obviously, I think it's a bell curve. I live in the real world. Some people are going to abuse it, but it's going to save some people's lives. It's just like Ozempic. Like when it first started coming onto the scene in the zenith of the culture and our understanding of it, the emotional younger part of me was like, nah, fuck that. You got to do it the right way. But how many fat asses do we know that aren't going to change? They just aren't. And just walking around, they're going to cost the system more. Just doing that. So in this case, if we can give them a pill to reduce their morbidity, great. Fuck it. Let's do it. It's going to save lives. So I kind of see it the same way here. It's going to save, if it saves one person's life, I mean, that's a good thing. And I wish I knew what my test was supposed to be versus what it is now. I don't know.
Yeah. Well, I was just going to say, I think that's a great kind of comparison. I think they probably have to be used in the same kind of light in that they're part of a bigger process. I don't think it can be. So we're very good. Again, I think we're very good in the West with like, you have problem X, take pill Y. That'll fix you. Job done. Right now, next patient. And I think that potentially was where we're leaving a lot on the table. I think it can be like Ozempic and that kind of entire family of drugs. I think they can massively be abused. I think there's something that's going to and has been shown to cause loads of potential dramas. But I think they could be a really good catalyst to like that person who can't exercise and can't get out to kind of lose weight in perhaps a more organic way, maybe can now start to do stuff but it has to be, okay, well, there's an on-ramp planned where we're going to 6 months, 9 months, 18 months down the line, we're going to be phasing you off this, but you have enough momentum where you're now good.
Yeah.
And we've paid attention to bone density. We've paid attention to kind of maintaining muscle mass. And I think the same thing could be true with the test side of things, but not in the same application. I don't know that it should be like the first step with the view to come off. But I think it could like, okay, this person's flagged low test and it's not kind of following something that's kind of atypical. They've had a back-to-back deployment, or they've been pulling like crazy overtimes, but it starts to flag. And then that person then can go forward for like further investigation, be it sleep, nutrition, lifestyle, but that's effectively then, this is such a crappy term, I hate it, but it's effectively a force multiplier for those specialists, because that's always been the kind of the criticism within H2F, as far as I've understood it, is that there just isn't enough nutritionists or sports psychs or S&C coaches. Whereas if you're starting to flag people, that's like, instead of, okay, well, you've got, I don't know, arbitrary number, 5,000 people to look after. Well, actually 364 popped up on the list this month. That's a huge, that you can now actually start doing something with that number.
I'm excited. And we haven't even talked about research potential.
Yeah.
Democratization of the cost of testosterone testing is going to be less now because of this.
Yeah.
So you and I, to put things in perspective, if you've never done this, now this, I'm sure it's more expensive now in today's economy, but I paid around $450 for a complete blood panel, a focus on performance. I can't remember the name of the company. I think at the time it was called Wellness RX. And then I went over with a very intelligent primary care who knows what he's talking about when it comes to endocrinology. And we went over line by line, like what was going on with my blood. And that was like in 2000. And it's hard for me to I don't want to pay for that again. I got close enough. But if it was like a $20 to $100 test, I would be, more open to doing it regularly. That's a big reason why I don't do it. It's like, that's a lot of money for something that I'm not even sure how much of a difference it could make.
I was going to ask you, what was the kind of, you don't have to kind of get into this too much if you don't want to. What was the thing that led you to get in that? And then what was the slow what's of it? Again, cut this if you don't want to talk about it.
No, I do want to talk about it. I talk about it all the time when I'm teaching the guys and girls. Right around the hours of 3 to 4 p.m., I'm doing everything right. I'm eating correctly to my knowledge. I'm respecting my sleep. I'm getting workouts in. Right around 3 or 4 p.m., I would fucking hit a wall hard. And I know I'm not the only person who's feeling like that. Now, keep in mind, this is mid-20s to mid-30s, low 30s. So I'm not like...
And you weren't serving at this point, G?
No. This is at
okay.
Exos. I was at Exos. And I didn't understand what was going on. So I decided to do due diligence, particularly with, at that time I was working in the Florida facility, which was 95% tactical guys. So I'm like, maybe I need to get my blood looked at. We work with a doctor, Dr. LeMay, who's still down there, and he does blood tests for everybody else regularly. So I'm like, you know what? Fuck it. I'm going to do it too. And Exos at that time was offering a very similar blood panel. Like, it was a benefit. So I went through them. I got their blood test and I took it to Dr. LeMay. And what he saw, if I just looked at it myself, I wouldn't know. Like, that's why you go to an expert. I wouldn't know what the fuck I was looking at. And I remember cortisol levels were normal. Test was normal. I thought it was test. Again, another reason why I don't know what the fuck I'm talking about. So test looked normal. So if I had looked at that, I would have left it at that. DHEA was low. DHEA, for those listening, is the mother hormone. So it's responsible for production of estrogen, I believe cortisol, and testosterone. And what Dr. LeMay told me was that my body was pulling all the levers it could to keep cortisol where it was. And that's why my DHEA was low. I know it's not just one thing, but my DHEA was pretty low. And we started supplementing with that. And it changed my life. So supplementing with vitamin D and DHEA. And within a week or two, that fucking hitting the wall at the end of the day, went away. It was fucking weird. It wasn't weird. It was that's what I knew what I was supposed to be feeling. So.
Just really quick. Correct me if I'm wrong. I think DHEA is still on banned substance list. So if you're listening and certainly at home, I think if you're listening and you're in a sport where they test and you're thinking, yeah, that's how I feel, I'm going to do the same thing, double check that. I haven't touched world anti-doping stuff in 10 years probably. It definitely used to be on the list. So check that. Sorry, G.
Thank you. Yes. Yes, that's what worked for me. And when I'm teaching guys about this, like that's the message I send is like, hey, that's me. It would be idiotic for you to assume that's what you're low in. Because the other guys, it would be like cortisol would be fucking sky high. So the solution for that would be different. Like, so anyway, I do, again, it's not financially, for me anyway, reasonable to get that because they want you, I think, if we were to ask Nick Barringer, he would probably say something around like every month to 6 weeks. That's a lot of money, man, for testing.
Yeah.
So,
especially if the spectrum's so wide, especially if you're testing like everything.
Yeah.
I know we have like a big push in I assume professional firefighters as well, but like in the volunteer world, because we don't have like medical backup, they try and push you every year to make sure you get like a full panel because of just the cancer risk nowadays with stuff.
Yeah, it's crazy. And I think about, now, I remember there's a firefighter who doesn't live very far away from me. I just ran into him, and it's frustrating because these guys they accept, how many people do we know that just accept this is I have to feel like shit for the rest of my life. That's just how it is. Like, no, you don't. It drives me crazy too.
Yeah. And I think that is obviously with the podcast that we're on and the product that we push. I think that's like so true in training as well. Like if whatever you're doing is beating you up, if every time you squat, I was definitely in this camp probably a decade ago. If every time you back squat, your knees hurt so bad that you can't sit down without wincing, and there's probably something going on there. It's probably worth maybe trying to do something a bit different or think about it. And it doesn't mean you're wrecked and that you'll never squat again. Switch something else in.
Yes, absolutely.
Yeah, just don't accept that as being the status quo, I guess.
Acceptance. Yeah, there's the company I served with was over, obviously it's like fuzzy, right? With people leaving and people coming in. But let's say around 100 people, a company size element in Marine Corps. I can't tell you how many of them are out of shape. It drives me crazy. It's like
now or when you were in?
Now.
Okay. Yeah.
They've completely which I get it. It's called working out. It's not fucking a great time. And I'm not saying working out's going to fix your diet, but goddamn, dude. Giving me a bad name,
Yeah. Well, that's, I guess this is kind of semantics really, but that's where personally, and I think as a company, we've had a big push towards moving away from working out and moving towards training. Yes. And there has to be a reason for it. You have to, there has to be something you're getting after. It's very hard when we work with people so guys who are just signed up for a subscription, they get in touch and ask for advice with training programs. We are all about that. We'll spend as much time as needed to get you squared away on that stuff. But it's really hard when there's no goal, when there's no end state. And it doesn't have to be that you're going to buds. It doesn't have to be that you're running some stupid 100-miler like G would like to do. It doesn't have to be a specific event or a competition or anything like that. But you have to have something, I think. I think it's really hard to just, both for coach and athlete, just to kind of go through the motions. I think at some point you're gonna find it tough. And if you have this is my why, even if that's, I want to walk my daughter down the aisle, or I want to be able to play with my grandkids, or I just like going out with the boys on the mountain bikes, whatever that is, finding something is huge.
Yeah, for me, it's that. So the Grail race, I've mentioned this before, is a Cocodona 250. I just found out the entrance fee is like $2,000, which is like, I'm going to pay $2,000 to beat the shit out of myself for a week. Like, I don't know.
Yeah.
But I'm prepping for that, or at least it's in the ether that is something I want to do 2 years from now. So therefore all the training kind of reflects in a very strategic way, getting ready for that. You know what's going to suck though? It's like if I fucking put in for the lottery, because I'm putting 2 years, but if I get it this year, fine. We'll go for it.
As in 27.
At 27. There's a chance I don't get it. So then I got to do a whole fucking year.
Yeah.
So I also wanted to talk about revisiting. Let's go back to, let's say, testing for hormones. No one, or people are talking about it. I'm really interested on the premenopausal and menopausal side, estrogen testing or testing for declination. The reason why, something that people don't appreciate, post-menopause, frozen shoulder. If you have, obviously most of us have mothers, and you may have seen this happen before where their shoulders just fucking locked up and it's not cooperating. And there's such a dearth of information as far as the function of frozen shoulder. How does it work? And we just don't understand it, and you have to kind of let it run its course. Clearly it's hormonal, since it happens post-menopause. And I recently learned that the joints are actually responsible partially for producing estrogen.
Oh, no
So
way.
that can be related. Can be. We don't know. So that's
Interesting.
what's frustrating is like we have to start somewhere. And in my
Yeah.
mind, this is a good. And then of course, there's people. Why aren't they testing for estrogen? You got to start somewhere. Okay, I'll fucking take this one. This is a win. And hopefully over time we'll start getting more blood panel work. But how many women are dealing with that postmenopausal in the military or premenopausal dealing with bullshit that can be addressed hormonally? And I don't fucking know enough about it. There's just not enough information. It's really interesting to me.
Yeah.
What are your thoughts on that?
Yeah. I agree. I think the gap, and I don't want to take this in a direction that is completely off where we're going, but I think the gap between research and application is huge, especially with females. So I think that now it's easier. Like we also talk about kind of using wearables and things like that. Like now we are starting to collect data like organically, I guess, rather than it having to be a kind of a study that's commissioned by a lab or a uni. Like we're having tons of people, thousands, hundreds and thousands of people collecting their own data. Once we can start getting a handle on that and hopefully like closing that or reducing those question marks on like female performance, I think it's going to be so exciting. Like some of the ultra stuff, like some of the potential there for female performance in like your world, like ultra events. That's going to be a cool 5-10 years seeing what
it's
what's going to happen to like once we know this kind of training works on 6 male college guys who work out recreationally. So we're just going to apply that same method and hope it works on females. Like that's effectively how we've been working for the last 40, 50 years. So once we start getting like more insight, more understanding in how female and male physiology is different in terms of response to training and stress and stuff like that. Yeah, I think we're going to see some really interesting stuff in sport.
Yes, it's interesting is the word I would use. There was a movement there for a little bit, which I feel like if you're a male and not a coach, it probably wasn't in your purview or in your interest, but women need to train differently than men, like very differently. And it's just not fucking true. I mean, they do. There are certain things, but the amount of, let's say, difference that they were saying, I think was overstated as far as like train power versus strength. Endurance, it's weird. That's different.
Yeah, well, I think we don't really know. We don't really know for males. Like when you boil down a lot of isn't it something like BFR, like blood flow restriction training, is the thing that has the most research on it, and yet that's such a small part of most people's programs. Like there's so many we don't know because research has classically been limited to like a lab-based environment. And now we're starting to get more like practical application stuff and people who are like a broader spectrum of ability and experience level. We're going to start to have more of an insight.
Man, I kind of wish we had Nick on. Maybe we'll have him back on. But question for you. What are the must test blood markers for you, in your opinion? Like,
I'm not the person to ask for this, really. I think we don't have the same culture at home. So before coming to the States, I had never had the blood panel done.
Mm-hmm. Not even for like dyslipidemia, for cholesterol?
What's that, sorry?
For cholesterol?
Yeah, we don't have anything.
Oh, wow.
Yeah, I'd never had anything done. We are way more, again, socialized medicine, we're way more symptom driven. So if you're showing these symptoms, let's go and get blood work rather than the other way around. So yeah, I'm probably not the person for that.
That's really interesting because how now I don't want it to turn this into a socialized healthcare medicine podcast, but I'm just curious, like statistically speaking, if I have high blood pressure, I'm going to die sooner. It's just how it is. So like, how did if I'm not aware of that, like, how do you guys know, like, that you need to be on cholesterol medication? Like, how does that work?
So I think again, I was a slightly weird case because I was in the forces. So we have our own kind of medical system. I think they do like kind of checkups, maybe at 30 and 40, something like that, where you're encouraged to go for like a health, we call it like a health MOT or something, like a health checkup. But I think a great deal of my friends just don't go to the doctors unless their leg's falling off. Like if there's nothing wrong, you don't go. Which
is fine, except there's some things, right? Yeah.
So that was a real kind of like cultural shock for me coming here and used to like, well, you got to go every year or every 6 months, or whatever it is, even if there's nothing wrong. Because before that, I'd not stepped into a doctor's office for, I don't know, a little while. Because again, it's symptom driven. If there's something, if you're showing symptoms, then you go for investigation. Now, clearly there's pros and cons to that approach.
Yes, there
you're
is.
not risking the over-medicalization, but you are risking that the house is burnt down by the time you get the fire guys going. You know what I mean?
Yeah, that's really interesting. Yeah. I mean, sick care. Well, that's sick care, isn't it? Not healthcare.
Yeah. And that's like really, so again, this is kind of massively off topic, but like the NHS is under real strain at the moment, just with like the amount of people that require its care and the funding it gets and things like that. And really, I think the only way it's going to survive is shifting more towards a preventative medicine approach, where you're trying to get like ahead of that curve. You're trying to get ahead of that sickness curve. I guess we would say that though, because that's the world we live in. You know, like that's the world that you and I operate in.
Yes, absolutely. Brush your teeth. You know, you don't want to see the dentist. Brush your teeth. Yeah.
Yeah.
Interesting. Okay. So let's talk about, have you had a chance to review the TSAC schedule at all?
I've not. So perfect. Let's do this live.
Okay, great. So because I don't have it on the top of my head.
Again, for people who aren't listening, G, do you want to, as a director, do you want to talk people through what?
Yeah. Heads up, everybody. I am now, as of yesterday, the state director for the National Strength and Conditioning Association for Arizona. So yeah, yay. It's pretty cool to like, oh, okay. Like you guys respect me. All right, cool.
Yeah.
All right. Yeah. So let's see the schedule. So for those of you unaware, the NSCA, National Strength and Conditioning Association, hosts a yearly event called Tactical Annual Training. That's for tactical strength and conditioning. It is definitely an event that is more biased towards military first responder communities. So not necessarily practitioners. Practitioners kind of have to choose between NatCon, a national conference, and this. For me, this is my bread and butter. So I've gone to TSAC for the past 2 or 3 years, and it's because of the population. Like to be frank, if you're an NBA coach or NFL coach, great, but it's just not going to get my fucking blood boiling in a good way. So anyway, we will be there. Matt and I. Is Brent going?
I doubt it.
I doubt it. Yeah, I doubt it too.
Maybe, but I wouldn't think so.
Yeah, it'd be kind of weird for him to go, but he might go. Maybe if you guys reach out to him, if you're listening to this and you know him personally, let him know to go. All right. First thing, first timers orientate. No, we're not talking about that. I've never done that. Okay. Let's see. It's a cool event. If you are, for example, someone like Nolan, you're a firefighter, you're very much interested in human performance, you're trying to elevate your house, so to speak. It's a good event to kind of like connect with other firefighters who have done that or companies that have done that. So let's see. Ooh, a workout with Beaver Fit. That's cool. That's great. I don't think that's ever been done before because usually the fucking hotel gym is packed. I have to do that. All right. I'm just going to pick out ones that look interesting to me. Are you looking at the schedule, Matt?
I'm not. I can pull it though.
Well, wouldn't you know it? Interesting. One of the first talks, Hormones Under Fire, Nutrition for Tactical Performance and Long-Term Health. Talks about testosterone, cortisol, estrogen, and insulin. So we will be going to that. That's by Kelsey Bailey, a dietitian. And I'm going to try and stay away from the basic stuff. That sounds bad, but rethinking the squat for operators. I feel like we've talked about that, right? Yeah.
Yeah.
Okay. And I'll edit. And by the way, dude, I'll edit all the pauses out. It won't be a big deal.
Yeah.
Austin Womack. You know him? That name is very familiar.
Yes. I can't picture a face, but to be honest, I feel like so many of these names nowadays are people I've seen present.
Yeah, I think so for myself as well. So Austin Womack, I believe I've met him, fire exercise physiologist, will be presenting on periodization and suboptimal training. Things we've talked about on this podcast. Weird. Almost like we know what we're doing. Rucking.
I wouldn't go that far.
Yeah, right. Zach Nielsen will be presenting on rucking, improving output while reducing structural cost. Let's see. Or we'll be talking. I got to talk to him.
Yeah. You can't, if he's presenting, if he's doing anything, drop it and go to that. He's a man.
Mental health. Brad Hollingsworth is a friend. I didn't realize he was presenting. Mental health, first aid, and tactical coaching. He works a lot with law enforcement.
Oh, cool.
Ryan Carroll.
One of the OGs.
So this is something that we need to talk about, Matt, and I feel like we need to have someone on the podcast to talk about it. But the proliferation of data and data collection within military first responder circles, how much of it is relevant and how much of it is noise, which is interesting because people were talking about how noisy it was, 6 to 8 years ago. And now that conversation is coming up again. It's like, why the fuck are we collecting all this data?
Yeah, wow. Again, I know I've kind of probably said this on virtually every podcast we've ever recorded. I think that's where machine learning and using those kind of tools, that's going to absolutely change the game on this stuff. But I won't go into that anymore. I do have someone you can speak to about that. We can get on if you're interested for that. Though.
Absolutely. What about, so there's going to be a talk on VO2 max for firefighters. So
Nice.
as a volunteer firefighter, what kind of testing are you doing? Because I know in Tempe, the Tempe Fire Department has to do like a treadmill test, or it might be a bike test actually. And there are some flaws with that for VO2 max. What are your thoughts as far as that goes?
So certainly volunteer in New York, New York State. We don't fitness test. I think there was a move a little while ago to try and bring something like that in, like a kind of a mandatory test, so that you, in theory, at least reduce the risk of someone going man down who's out of shape. That, as far as I know, like never kind of was stood up. Certainly speaking for kind of local companies, I think you'd have a really hard time enforcing that because you just don't have the manpower. You almost can't afford not to bring people. Like, well, we're very rural, so this is, I guess, again, this is different. You'll maybe roll up on a structure fire, something like that, and you might have 5-6 people during the day. That's your whole crew. So you then can't stand at the door and be like, nah, you didn't pass your fitness test. Go on, back to the trial. You don't, like, I'm not a chief, but if you're in that chief position, I don't think you have that luxury. In the same breath, I think just like the test stuff, though, probably looking at something like that is a step in the right direction. The way you do it, though, especially in the volunteer world where people are volunteering their time, there's no financial compensation. I think you have to be careful how you do that. And it has to be education-led rather than like the stick approach.
Right.
That's just kind of my perspective. I know Nolan has a lot of insight and some pretty fiery opinions on fitness testing in the pro side, in the full-time side. So he's definitely a man to ask about that. I don't want to talk about him.
Now, when you're doing your job, I mean, are there people who are clearly not in the same shape as you? And then how has that ever, like, do they ever look at you and be like, oh, I need to be more like him? Or like, how does that work? Because to me, I hear liability.
Yeah. And that's kind of the risk. And I think the killer, I assume this is the same across all firefighters, not just volunteer, is like cardiac event within 24 hours of it.
Sure.
Of a shout. That's kind of off the chart high. And I think it's going to be sort of dehydration and stuff like that as well, just because this sounds like a really obvious thing to say, but you sweat a lot. And it's not just because you're in a fire, it's like the gear. And I think not having a sports science culture where I'm sweating, so I need to drink water and electrolytes afterwards to replenish that. Like, let's crack a cold one because it's a job well done. We're rural, so I can only speak for kind of where we are, but it's that culture, not data, sports science.
Fascinating.
I'm in kind of reasonable shape, but I'm probably very much in gym shape. Here I serve with a ton of country boys who have never been in a gym in their lives, but the stuff they can do is insane. Guys in their like 60s, 70s, a couple in their early 80s who are like physical monsters just because that's all they've done all their lives. And it's those people you would look at and you would think from a classic S&C perspective, they need to like cut down on the Big Macs and get some exercise. And they're not in shape, but the work that they can do, and some of that's kind of work ethic, but the physical work they can do just because they've a life of hauling hay and like looking after cattle
low
and
intensity
like
over an extended amount of time. Makes a lot of sense.
Yeah. Like never mess with a farm boy.
Hey, I've seen it firsthand. It's pretty wild. What that can do.
But it's, sorry, to kind of get back to your point, I think that's kind of where we have to be careful in strength and conditioning, sports science, to respect the culture of these organizations and not just kind of coming in with, well, this works in football, this works in wrestling, so this is how we're going to run it. Because I think you're going to be pissing in the wind, for want of a better term. Like, you're not going to get traction. You need to understand the cultural side of things.
Well, to further that, I mean, you're talking about the buy-in piece. Or adherence piece. For me, there's also the actual risk of injury. So I'll take a quick story. So I'm not going to name names, but the company I used to work for took over an athlete that I was working with, a tactical guy, a Bubba. And the program that he was given was very basic bitch. And that's not an insult. Like, it was vanilla. There's nothing wrong with the program. It was a good program, except this is a tactical athlete. And I remember when I was told what this guy was doing, and I was no longer working for them, I was like, oh, that guy's going to get hurt. It was like something like goblet squats. And that's exactly what happened. He got hurt. And that's talk is cheap. It's easy for me to say that. If I was coaching him, it wouldn't have happened. But we've talked about the injury rates under my care before. There's a lot of implicit knowledge that you as a practitioner has that working with military first responders, that if you were coming from sport, these subconscious, unconscious rules that you kind of laid down through experience, you don't have. And that's another reason it wouldn't, and I'm being very reductive when I say this, it wouldn't work. It's because you're applying your experience from sport, which is just fundamentally different. Not fundamentally, but there are definitely parallels, but the rules are different. When you're, carrying around a fire hose or having to deal with a blastoma, like fucking brain cancer as a real risk, not a torn ACL, the rules are fucking different. So, so it's something I've learned to appreciate about my body of expertise. And I guess another reason why I like TSAC is because all of those unspoken rules that are just there that no one has successfully articulated, that's the norm. Whereas if I try and take that and apply it to sport, it's not going to work.
Well, that's exactly what I was going to say. That's a huge shout out for TSAC. That's something that, again, we don't really have a TSAC in the UK. So our NSCA is the UK SCA, UK Strength and Conditioning Association, and they're great. They're much, much younger as an organization, as a governing body than the NSCA, and do a fantastic job. But there isn't, because tactical strength conditioning is done in-house in the military at home, almost exclusively, there isn't that same market yet. So I think they're doing a lot of work with those specific organizations, like with the RAPTC, like the Army Physical Training Corps. I think they're doing direct work with them. And it's awesome. It's definitely moving in the right direction. But I think that's where TSAC that's where the NSCA and specifically the TSAC arm needs a massive round of applause. They've done a really good job of this isn't just training for football, but you're wearing camis. Like they respect that difference.
Right. They just released the second edition of their tactical strength conditioning text. So just a shout out if you're interested in that. If you have questions on education regarding, you feel free to reach out to Matt or myself and we'll be able to share. Let's see. Nate Palin and Chris Frankel are presenting on a scientist outcome-oriented interpretation of, that's a operator coach and leadership advantages. That was a lot. So what now? What regarding data? We talked about that. That's going to be cool. Acevedo is teaching that. Let's see. Marksmanship and skill acquisition. As far as law enforcement goes, I'm really interested in see. They call it biomechanics, but that's what they're talking about. If you put marksmanship in a presentation, I think even if it's TSAC, you're probably going to scare people off. Let's see. All right. Hydration, always. Megan's teaching that. So we'll go see her. Sponsored by Drip Drop. Dude, how do I get sponsored by Drip Drop? Joe Cruz talking about H2F. Dude, Wednesday, day 2 is fucking huge. TBI recovery. Oh, there's going to be a lot. See, that's another, TBI recovery in regards to the tactical athlete is a little different than football.
Yeah. Again, like an opportunity to share and kind of a lot of lessons to be learned. But I think, again, it's your application is going to be different.
Yeah. Let's see. Recovery science. Wow. I guess the last day is all about recovery. Run, road, rider, resistance. Anyway, breath work. Behringer's talking about solidricide. I'm really excited to see that. Training tactical women. All right. Interesting. So it's our intent, Matt and I, to also record at least one episode while we're there. Hopefully we'll see some of you there. I'm not sure who, if any of the listeners will be there, but it'll be great if you do listen, catch up with us. We'll be wearing SoftLeak gear. All right. Matt.
Mostly because that's all the clothing that I own.
Yeah, right. That's all I wear, really. Yeah. All right, man. I feel like we've hit a lot.
We've been around the houses, I think. Yeah.
Yeah. What are your thoughts?
So broadly, I think that. Sorry, mate. You go. What'd you say?
Are you getting your test tested?
Well, I think I probably need to.
Yeah.
Yeah. I think broadly that policy change could be a real good step in the right direction. And again, it's kind of recognizing that hopefully this is part of the process. This is kind of the right trajectory. We're not necessarily there yet. We're not at the right location yet. I think that if you're listening and you're considering TRT, that's probably something to explore. But I think make sure all the lifestyle factors are checked first.
Yeah.
And you probably want to do that under the guidance of someone that knows what they're doing and recognizes, assuming you're listening to this and you're in a tactical occupation, someone that understands what that looks like. Because obviously, like G said, what we do isn't normal. So you can't really kind of use normative data too strictly. Where else do we go after that? Around the houses. Blood work, I think, has the potential to be awesome, but don't look at it in isolation. I think consider symptoms and consider how you're feeling.
Yes.
On top of that.
Yeah, I was going to mention, so Dr. LeMay, his practice is called Regenesis Performance. He's based in Pensacola. We've definitely reviewed work online, and that was several years ago, so I'm sure it's easier now. I would recommend, I'm not trying to endorse him. I'm just saying that's who I use. The reason I'm bringing him up is because he works with military first responders. So that's the other thing. Like if you're going to, there's a men's health clinic that's not far away from me, and it's clear that they're like targeting the alpha male and like that, bro, like that kind of vibe. Like that's fine.
That is my kind of place.
Yeah, right. There's nothing wrong with that. But I want to go to the person who's working with people who are like me, if that makes sense.
Gee, I don't want to put you on the spot, but this is something I know nothing about. Do you know if there's any like non-profit charities that can help people out with this kind of stuff? Like if obviously VA, I'm assuming is a potential, but is there anything else if they've not served in the military or if they have served in the VA?
Oh, that's a great question. I am unaware. I will say good fucking luck if you're trying to do it through the VA. Maybe now it'll be different.
Again, I have no appreciation of this stuff. So
yeah, I've tried for several years to go through the VA because I have the blood work. I have the blood work to show that there was a deficiency. And we talked about this before with a different topic, but the amount of pushback I got for just wanting to follow up on my data to see where I was at was incalculable, to the point where when I said fuck it and I went private and went through my insurance to primary care, I didn't realize how easy it was. It was like, hey, I think I need to get my DHA test. I was like, oh, sure. It was not a fucking like 5-minute conversation as to why do I need that? Why do I think it was an argument? It turned into two different doctors. It turned into an argument. And I stopped going to the VA for years for that. So I guess I'm saying that because if you're utilizing the VA, it's going to be you're hitting a wall. And if you're frustrated with that, just know that there are other options. It might be worth your time to go primary. I'm not saying bashing the VA. It's just they're not equipped to do that. Going back to Matt, what we were talking about, sick care versus healthcare. They're looking for
they're putting the fires out.
Yeah, putting fires out. And I don't even know what symptoms I would have to, they have the ability, but I don't know what kind of hoops they have to jump through or what I had to say for them to be okay with it. It was like really frustrating. So
okay.
Symptoms for me was fatigue that I was unaccustomed to. Now looking back, here's a big question that I have for myself. Knowing what I know now, and looking back, particularly after working with Paige, was I not getting enough protein? Was it as simple as that? I don't know.
I think a huge one in our world is just not enough calories. Like not
or that.
Again, sorry, this is like a topic for another conversation, but for another show.
Dude, I weigh 200 right now, which is too heavy. I need to lose about 15 pounds or so. But then I was like 175, 180. I was really lean and I was not very big. So I'm just wondering, like that's to your point, Matt. I'm wondering about the nutrition aspects. What was I missing? Especially now having done all the actual protein I'm supposed to be eating, how hard it is compared to where I was.
Yeah. And again, kind of to wrap this up, I think that's where early testing can be really useful because as long as it's not an instant, like, okay, you flag low, you start shots tomorrow. It's okay, well, there's something going on here. Let's explore further. That's awesome. Whether you're doing that through this new policy or whether you're doing it off your own back through your own healthcare, I think, understanding what's going on and why is kind of the way to go.
Oh man, and we're coming up on the tail end here, but now I have questions on. So I've seen it. And I'm sure you have too, this push to get people to get full body MRIs for potential brain tumor. Listen, friends and listeners, I don't think it's necessary. I think it's a mechanism to sell you shit. And I'm not saying don't get an MRI if something isn't wrong. I'm just saying like there are other steps to take before you go that far. And if I had to pay cash, I just had an MRI done on my head, just my head, $8,000 if I were to pay cash for that. So that's a lot of money for, at the end of the day, everything's okay.
I was going to say this is kind of, again, zero medical licensing or credentials here in the States, but someone who's worked in rehab, like that's what I did in the military. I can say from experience, once you see that scan, even if you're like asymptomatic, once you see that scan, you can't unsee it.
That's
so
good.
Just be aware of that. That's opening Pandora's box for sure.
And as far as disc herniations in the lower back, over 50% of the people in, like, let's say there's 100 people, over 50% have disc herniations. They're just asymptomatic. That's the fucking reality. Are you asymptomatic? That's what we should be looking at when it comes to herniations. You also have to be very careful with, like you said, Matt, like you can't unsee it. Like ortho sees that and you're like, oh, we got to fix it. That's his fucking job or her job. Like if you can solve it kinetically, meaning like in the weight room with nutrition, proper sleep, maybe you should do those before going. I can't tell you how many times it happened every fucking 6 months. I would work with somebody. I realized, and I'm like paraphrasing with it. I think I didn't need that surgery. You know how many times I fucking hear that? It drives me, It doesn't drive me crazy. It's just like, it breaks my heart. It's like, man, fuck, you came here a year prior, you'd be fine. You wouldn't be under the fucking blade. And so much of it is because it's just, and it's ingrained in our culture. Like something's wrong, you go see the doc, PT is not heavily weighted. It's not very heavily valued. Same thing with strength and conditioning. And it's because so many people don't know what the fuck they're doing in the weight room. Yeah. Oh man. Got me amped. Yeah. All right. I feel like it's a good place to finish. What do you think?
Yeah. Before you start chewing glass.
Yeah. All right, friends, listeners, you guys have a great one. We'll see you on the next one. Die living.